Hi everyone, welcome to my YouTube channel Indian Doctor. In this series, we are discussing UPSC Medical Science Optional Previous Year question. Here is a General Medicine question from the year 2021. A 60-year-old diabetic male patient presented to emergency with acute onset central squeezing type chest pain, which is severe in intensity and not relieving even after taking rest. What is the most probable diagnosis? How will you investigate the case to reach the diagnosis? Outline the steps in the management of the case. The first part is what is the most probable diagnosis, and it is 2-marker question. So we list out the differential diagnosis in such a case. Here they have said the patient has acute onset chest pain, severe in intensity and not relieving even after taking rest. So the differential diagnosis here we can write as myocardial infarction, angina pectoris, pericarditis, pulmonary embolism, pneumothorax. And finally we conclude as most probable diagnosis in this case will be myocardial infarction, and the reason being it is a squeezing type of chest pain, not relieving with rest, comorbidities, it is an elderly patient and diabetic. Moving on to the second part, how will you investigate to reach the diagnosis? So the investigations that we can do in such a patient is, first is ECG, and what are the changes that we can see in MI? There is ST segment elevation. You can draw a pictorial representation in a normal ECG and in acute elevation how the ST segment changes. Cardiac biomarkers, we will do a serial measurement of serum troponin. In unstable angina, there will be no detectable rise in troponin. This table shows different cardiac biomarkers, troponin T and I, CKMB. When it begins to rise, peak, and when it becomes normal. Troponin T and I will begin to rise by 2 to 4 hours, peak in 48 hours, whereas it remains elevated up to 2 weeks. The difference with CKMB is it becomes normal within 72 hours. The main difference lies in when it becomes normal. The CKMB also begins to rise within 2 to 4 hours, peaks in 24 hours, whereas it begins to normal within 72 hours. The only difference, we have to remember this. The next investigation is chest X-ray. Here we will find the heart size to be normal, but chest X-ray can be used to rule out other pulmonary causes like pulmonary embolism or pneumothorax can be ruled out using chest X-ray. Coronary angiography, it can be both diagnostic and therapeutic. Like therapeutic in the sense revascularization can be done in patients with risk of future events, and also used for patients who fail medical therapy. And in whole blood count we can see leukocytosis. So these are the investigations that will be done in this patient. Third part is outline the steps of management in this patient. So I have given a flowchart kind of format. This will fetch you higher marks. Let us see that. So we have to do an immediate clinical assessment followed by ECG and cardiac biomarkers. Along with that, we have to provide oxygen support and continuous cardiac rhythm monitoring. We have to give tablet aspirin 300 mg, tablet clopidogrel 300 mg orally, injection metoprolol, that is a beta blocker, 10 mg intravenous route, and then transfer the patient to cardiac intensive care unit. In ST segment elevation MI, when the patient presents within 12 hours of onset of symptoms, then we have to go for reperfusion therapy, that is percutaneous coronary intervention or thrombolysis. If PCI is possible within 2 hours, we have to go for percutaneous coronary intervention. If it is not possible, then we go for thrombolysis. So after percutaneous coronary intervention, patient will be kept in maintenance we will see what is thrombolysis. If patient we are not able to do, the hospital doesn't have facility for percutaneous coronary intervention, then the patient is taken up for thrombolysis. Along with thrombolysis, we have to give anticoagulation. If it is failed thrombolysis, then definitely we have to move for percutaneous coronary intervention. Patient is shifted to any other center where PCI can be done. If suppose patient is not presenting within 12 hours, it is more than 12 hours from onset of symptom, then we have to have risk assessment of the patient, whether the patient is still having an infarction or what. We have to risk assess and then hospitalize the patient for coronary angiography and then do necessary steps. If thrombolysis is not been done, whether we can do delayed PCI is possible, then yes, we can go for percutaneous coronary intervention. After all this, the patient is kept in monitored maintenance phase and started in hospital medication. What are the medication? Aspirin, clopidogrel, low molecular weight heparin, statins, beta blockers, ACE inhibitors. So this will be the outline of management of this case. So representing in a flowchart format will definitely fetch you higher marks. This can be one way of representation, or I have even detailed what management, each step of management. First is we have to provide analgesia to the patient. Patient is having severe chest pain, so analgesia has to be provided. Injection morphine, that is opioid, has to be given intravenously. It will relieve the distress, lower the adrenergic drive. Next is percutaneous coronary intervention. What are the indications for that? If the ECG is having new bundle branch block, or there is a characteristic ST segment elevation. So those are the indications, and it is the treatment of choice for those who are presenting within 12 hours. Then the thrombolytic therapy that we were talking about, the drugs used are tenecteplase, retiplase. These are analogues of human tissue plasminogen. Next is antithrombotic therapy. That is tab aspirin 325 mg within first 12 hours, then it has to be continued daily. Tab clopidogrel 300 mg stat followed by 75 mg daily. Then the anticoagulation, this will prevent the risk of reinfarction in the future, either unfractionated heparin or low molecular weight heparin. Nowadays low molecular weight heparin is preferred drug. Like enoxaparin, the dose is 1 mg per kg twice daily, and it has to be continued until coronary revascularization has been completed. Next, anti-anginal therapy. Sublingual glycerol trinitrate 300 to 500 mg. Intravenous beta blocker, that is atenolol or metoprolol, has to be given. Renin-angiotensin blockade, this is for long-term treatment. The ACE inhibitors like enalapril or ramipril can be given. This will prevent ventricular remodeling, and it also reduces a recurrent MI. The last is lipid lowering therapy, that is atorvastatin 80 mg daily. So this is a brief discussion of myocardial infarction. Hope it was useful. Thank you.